Thank you very much for the kind introduction, Glenn, and it's really lovely to see so many friendly faces in the audience this evening, so thank you very much indeed for coming. Many of you I have known or worked with for over 20 years, so actually could have done this presentation for me, and believe me, I tried. I did try a little bit of bribery and without success, so you'll be stuck with me just for a little while. So the heart and soul of cardiac surgery. The heart bit is pretty obvious. I've been a cardiac surgery or cardiovascular nurse for the best part, scarily, of almost 30 years. The soul bit comes in a variety of forms during this presentation. Firstly, though, I would like to say that the work that I present to you this evening has come from a real collaborative team effort from a range of really inspiring and dedicated professionals that have given me a lot of opportunities along the way. And I have to say I've really needed them because I didn't have a plan. So I really would have been very stuck without them. And to be quite frank, that's quite ironic for someone who actually plans everything else from within an inch of its life. However, it turns out at primary school I did want to be a nurse if my career in hairdressing didn't pan out. But I just didn't think I was going to be a very good one. But as I was kind of looking through this autobiography, which I probably did at age 8 or 9, we kind of hazard a guess, then I came across this, which we were obviously told to write in the front of our autobiographies, but it's the first verse of a poem from Walter de la Mare, which was, "As long as I live, I shall always be myself and no other, just me." And I think this probably has summed me up quite well. I haven't really chased a particular role or opportunity or position in any particular way, but I have taken opportunities as they've arrived. So I've kind of followed my nose a bit, and if I'm going to keep to theme, a little bit of heart and soul as well thrown in. But I've taken projects either because they were interesting or I got to work with some really great people. So this is where a little bit of my soul comes into this as well. But despite the lack of plan, I've done okay. So I actually started my journey. So I thought a career roundup might be quite useful. So I actually started my journey here at King's as a nursing student. And I was probably one of the only few, sorry to say, that enjoyed the research lectures enormously. And I actually got a first taste of clinical research in my third year placement on ICU. Quite by default because I'd dislocated my shoulder, so I got to work with the nurse consultant for a week or so. But I knew early on that I really was interested in research, and that's what I wanted to do. So I actually got my first research job with Professor Harry Hemingway, and I didn't have any experience, but he gave me a research nurse job on a large epidemiological study called the ACRE project, which was about completing follow-up and validating MI diagnoses in 13 hospitals across London. Now, it led to my first proper research publication, and I just wanted to highlight it in red, in the New England Journal of Medicine, no less. Dizzy heights, I've not yet repeated, but really this job was my apprenticeship, if you like. It gave me a lot of insight into things like data quality, the importance of data definitions, and how you construct those studies, but also in terms of multi-center studies, big data sets, and prognostic factor research. And those are methods that I continue to use today. However, I missed being clinical, and through a mutual friend, I met Professor Hugh Montgomery, evening Hugh, and Hugh was from UCL, and he was looking for a clinical research nurse in cardiovascular genetics. Absolute bingo. And the rest, they say, is history. So here I stayed working with Hugh in different guises and progressive roles for the best part of 15 years. And I worked with him and a fantastic team of people to develop studies focusing on physiological mechanisms, biomarkers, gene-environment interactions, And I worked with healthy volunteers, cardiology and cardiac surgery patients, as well as elite athletes and the army. So importantly, while I worked really hard and I learned more than I can begin to describe this evening, I also had the most fun you could possibly hope to have at work. I also did things I never dreamed I would be doing, to be fair, but it was an amazing experience. And during all this time, I worked clinically, from a clinical perspective, between the cardiology and cardiovascular departments, first at the Middlesex Hospital and then at the Heart Hospital. And it's really lovely to see colleagues that I'm currently now working with in the guys here at King's from my time there. And one of the key people, actually, from that time is Professor Sir Bruce Keogh, who I met when he agreed to be my second supervisor for my PhD. But I met him in the pub when he was out with Hugh and other colleagues, and I kind of cornered him a little bit. And after chatting, I said, will you be my PhD supervisor? So he agreed. I don't know how much he'd had to drink at that point, but he never had another PhD student after me, which may say something. But we were there as he was just starting in his role as medical director at the Heart Hospital, which was a big coup for me professionally, and I was honoured to be guided and advised by him for an exceptionally long time. Now, after I did my PhD, I wanted the PhD to count, and at the time, there weren't a lot of post-doctoral opportunities, particularly for nurses. And back to the big data, I took on the role of Chief Operating Officer for the National Institute for Cardiovascular Outcomes Research. And this is an organisation that manages the national cardiovascular audits, which now holds around 6.5 million records of care. Now, during my time there, the impact and political influence of such data was really significant. So it was a completely new experience for me, working very closely with NHS England and the Department of Health. And for me, one of the big advantages was that I got to work with Bruce again in his new role of NHS England Medical Director. So Bart's then beckoned. As I say, not for the first time, I kind of missed being clinical. And so being based then for the last 9 to 10 years at St Bartholomew's Hospital has been a real joy. It's host to one of the larger cardiovascular centres in Europe, and I was based also at the William Harvey Research Institute at Queen Mary University of London. And my role there was to develop research opportunities and clinical academic opportunities for nurses and allied professionals. Now, I'll mention a bit more of that work undertaken a bit later, but from a personal perspective, did I miss the picture? No, that's the picture. Excellent. But during that time, I managed to get my personal chair, which in itself was amazing, but to be the first nursing professor in cardiac surgery in the UK, and also the first and only professor of nursing at QMUL, was a real honour and a real testament to the belief of those who have supported and encouraged me throughout my career. And now I'm back at King's, which is great to continue championing and progress clinical academic careers, but also importantly to develop my programme of work on improving cardiac surgery outcomes. Both aspects of this work focuses on my work nationally and internationally, which Glenn has mentioned, both with the Society of Cardiothoracic Surgery, as a co-founder of an international network of nurses and allied professionals in cardiac surgery research called CONNECT, and as president-elect for ACNAP, the European Society Association for Cardiovascular Nursing and Allied Professionals. So I'm going to delve a little bit more into the actual research programme and its origins for me. But for those of you who maybe aren't so familiar with cardiac surgery, the first coronary artery bypass graft surgery in the UK was around the 1950s, and there's been a lot of advancement during that time and through the 60s, seeing the advent of cardiopulmonary bypass, mechanical and tissue valves, and the first human transplant. By the late 1970s, there was a national cardiac surgery register, which eventually, over many years, then formed as part of NICOR. And at that time, over 11,500 heart surgeries were registered in the UK, with a 9.8% mortality rate. Now, if we look at mortality now and numbers, we do over 26,000 cardiac surgeries annually. That's down on the 34,000 pre-pandemic across 35 NHS hospitals and 3 in the Republic of Ireland. Mortality has significantly decreased and has continued to do so over the last decade, with mortality rates for elective cardiac surgery at 0.49%, isolated aortic valve replacement at 1.2%, and for combined surgery still at 2.5%. But despite falling mortality rates, increasing age, more women with higher risk are having surgery, and there's more complex surgery being undertaken. And from a clinical experience, I was really aware of the importance that surviving is not necessarily the ultimate definition of surgical success. From a patient or indeed a nursing perspective. So on occasions, we would see patients with really protracted and debilitating recoveries, particularly in that in-hospital period, and that patients and their families were really unprepared for. Now, if we look at morbidity, up to 48% of cardiac surgery patients experience at least one complication. And if you experience just one complication, whether that be major or minor, you can have an increased length of stay, increased morbidity within the first 6 weeks after surgery, requiring the need for more community health support, and your quality of life can be worse at least up to 3 years after surgery. And we tell patients that they'll recover in 6 weeks. If you're frail or pre-frail, you're also likely to have worse outcomes or poorer outcomes, and morbidity, frailty, health-related quality of life, and patient-reported outcomes are not things that are routinely collected in our cardiac surgery patients. So my PhD focused on developing a cardiac version of the post-operative morbidity survey to measure morbidity after cardiac surgery. So based on the data I collected, which was on 450 prospectively recruited cardiac surgery patients, a 13-domain model shown here was developed and internally validated, where the presence or absence of each of these morbidity domains was assessed on days 1, 3, 5, 8, and 15 after surgery. Internal consistency was achieved, which means that for days 3 through to day 15, we could use this as a score of total morbidity burden after surgery. So if we look at those with CPOMS-defined morbidity here in the pink at the top against those without CPOMS-defined morbidity, you'll see that those with the morbidity have significantly longer length of stay in hospital. And at the time we were doing this, there was a lot of focus on the use of blood and blood products, and the focus was really on the impact on mortality. So we looked very much at the focus of using blood products during cardiac surgery and the impact on morbidity. And what we found was that if you have preoperative anemia, shown in the top graph here, on days 3 and day 5, your CPOMS score, you had a worse outcome if you had preoperative anemia. Now, if you had preoperative anemia, you were 3 times more likely to require a blood transfusion. And those that had a transfusion had higher CPOM scores on each of the post-operative days. But we also found that it's not just the total morbidity burden that's important, but the pattern of morbidity. So this table is a bit kind of dense, but I'll just summarize the main things. So we compared aortic valve surgery, aortic valve replacement, when you have your chest opened, compared it to those patients that were having a more minimally invasive form of the procedure called a transcatheter aortic valve implantation. Now, TAVI is indicated for older patients not suitable for surgery, so although that comes in itself with increased risks, because it's less invasive, it is thought that to be quicker and with less complications. So in general, we found this to be true certainly on day 3. But if you stayed in hospital beyond day 3, what we found is that your length of stay actually is very similar, but it's the pattern of morbidity that's different. So if you had a surgical AVR, you would have more cardiac and hematological complications. And if you have a TAVI, you're more likely to experience gastrointestinal and neurological complications. So I'm just going to fast forward 10 years. So just kind of imagine 10 years has passed, and I'm now back looking at this, and it turns out not much has changed. So morbidity measurement is still poorly documented and not routinely assessed, although there are several models which we identified in this systematic review that pertain to accurately measure post-operative morbidity. We are doing some more work on this now, so there's definitely more to be done. However, there's also been a shift to health-related quality of life as part of determining surgical success. Globally, health ministers have stated that there is a need to invest in outcomes that are really important to patients. And in the James Lind Alliance Priority Setting Partnership in Cardiac Surgery, health-related quality of life was identified as the top priority. So this patient-reported outcome statement from the ESC, which I led from a cardiac surgery perspective, highlights a range of required developments, but specifically for clinical trials that patient-reported outcomes could be included and must be informed by patients, and that trial committees should have patient-reported outcome expertise. However, currently, less than 30% of cardiac surgery trials are reported to include patient-reported outcomes, and so that's something we need to address in new trial developments. And also, we know from our cardiac COVID study, which we obviously conducted during the pandemic, that those almost 30% of participants were depressed pre-surgery, and that health-related quality of life didn't exceed pre-operative levels until at least a year after surgery. This is not uncommon, with patients often quoting that they don't feel back to normal until at least 18 months. This work also highlighted that women are more impacted than men, with worse outcome scores at all time points up to a year after surgery. Now, it was this finding that the persistence of Sarah Murray, our lead PPI advisor, that work focusing on the impact of cardiovascular disease in women should be explored more. Specifically, the fact that they only make up 20% of cardiovascular surgery trial participants. We formed the Women in Cardiovascular Trials group, and in a recent Nature Reviews Cardiology editorial, we highlighted the wider societal and policy developments needed, in addition to the researcher-led responsibilities to ensure inclusion. We also now advise on trial design and delivery based on our understanding of the limited evidence of the barriers and facilitators to women participation in cardiovascular trials. So therefore, it'll be of no surprise at all to know that my current programme of work, which is supported by the NHR Senior Clinical Practitioner Research Award, and this funds part of my salary for 5 years, which coincides with me starting at King's last July, focuses on morbidity and multimorbidity, including the impact of frailty, health-related quality of life, and the underrepresentation of women in cardiac surgery. To date, initial projects have been generously supported by Bart's Charity, the Aortic Dissection Charitable Trust, and Heart Research UK. And I'm delighted to have forged collaborations, especially across King's Health Partners, including other King's faculties, Guy's and St Thomas's, and King's College Hospital, as well as reinvigorating work with former, I didn't say old, valued colleagues. And as Glenn mentioned in my introduction, cardiac surgery trials is something I'm particularly keen on, and they have previously been relatively limited in the UK. But they are on the increase following the Priority Setting Partnership and the establishment of the National Cardiac Surgery Clinical Trials Initiative set up by Professor Gavin Murphy at the University of Leicester. It's always an honour to be invited by colleagues to contribute to their trials, whether it be from a health-related quality of life, women in cardiovascular trials, or a nursing expertise perspective, and I'm involved in a number of trials currently. I particularly want to mention the ROMA-Women, which Glenn also mentioned as the Trial Steering Committee Chair, as I am the first nurse to chair a BHF-funded Trial Steering Committee, which hopefully paves the way for others to do so in the future. So I especially want to have a big shout out to our valuable contributions from our patient partners, Sarah Murray and Edward Hyde, who are both here today. And I'm delighted that Gareth can't be here tonight because he's away celebrating a big birthday. So their involvement has been really transformed the projects we have done and kept us as researchers really accountable. Edward and I have co-presented at the British Cardiac Society, and our cardiac COVID paper had 4 patient co-authors. Edward and Sarah also wrote their own paper for the European Journal of Cardiovascular Nursing, which was, again, probably a relative first. But I think shown here, just in the bottom right-hand corner, is work that we're doing that's currently funded by the Aortic Dissection Charitable Trust. It's given us the privilege to work with 12 patient partners and carers about their experiences of aortic dissection and shaping the research they want us to do. And without question, I think this has been one of the most thought-provoking experiences of my career, and I only hope we can do justice the trust that they've given us to deliver the work they want and need us to do. So previously I said I'd skip 10 years, so I'm going to address those 10 years now. I had a relative hiatus in doing research as my time at Director of Clinical Research at St Bartholomew's Hospital, and building nursing and allied professional research capacity and capability was the key focus. But during this period, I'm proud to say we supported over 40 funded predoctoral, doctoral and postdoctoral or research places, generated over £5 million worth of research opportunities. And I think this is also a really great opportunity to say how proud I am of the PhD fellows that I've currently and have been recently supervising, and all the fantastic work they've been doing relating to cardiac surgery and or health-related quality of life, and having their work recognised nationally and internationally. And I'm really delighted that Juan, who's here, has recently secured an early career researcher after his PhD has finished, and so will be joining us at King's to take that. And he's the first nurse and the first international recipient from the Foundation of Cardiac Sarcoidosis. So congratulations, and we look forward to welcoming you, Juan. But to build that infrastructure for clinical academic careers, we also supported that with establishing a diverse research in practice programme to integrate research as core business in clinical practice. And work that I think was particularly impactful was our research preceptorship programme for early career nurses, a programme funded by the Trust for Nurses to support ward managers in creating a positive research environment, and also embedding clinical academic, post-doctoral clinical academic careers in practice, which is the time when most people leave research, is because there's a real challenge in getting a job postdoctorally, and our model has been relatively successful and has either been adopted in part or in whole by other organisations or departments. And I'm really pleased that supporting clinical academic careers is something that I can continue to champion at King's. And I look forward to working much more with this wonderful bunch of people and to further their opportunities. And I'm really delighted that Catherine Evans, Deputy Director of King's Clinical Academic Training Office, has welcomed me into Cato to continue working in this area. So thank you, Catherine. And similarly, it's wonderful to work and learn from Professor Mary Malone, Vice Dean for Education, and Emma Menzies-Gow, Associate Dean for Postgraduate Taught Studies, to progress potential partnerships with Jo Carter, Director of Nursing at Guy's and St Thomas's, and Tanya Massey, Head of Nursing at KHC, to look at postgraduate cardiovascular courses. So it's time to wrap up. I think the key points are that I didn't have a plan, and I never have, but I've kind of done okay with that. I think it's hugely important there are so many more opportunities for nurses and allied professions now that weren't really around when I was kind of growing up, if you like. But I do think for me that had some advantages. I think it gave me a certain freedom. I could veer off, come back to clinical, go off and do other things just because they were interesting. And I do think that probably a little bit of my soul played a part in that. I was open to opportunities. I had the desire to work hard. And I think the key part is having the right people to work with to do that is key.
So I'm hugely indebted to a whole range of colleagues who I've mentioned this evening, but also to others over the last 30 years. But all the points I try and convey to others, that's really important. And the end goal, there's not necessarily one path in order to achieve that. So the heart and soul of cardiac surgery lies solely within the wants and needs of patients and their families. As briefly illustrated this evening, there are vast areas that we still need to improve and learn. And I'm very fortunate to be in a position to perhaps make some dent in some of those gaps, collaborate with colleagues aiming to do the same, and support those developing clinical academic careers to continue the work far into the future. But this has all been about my professional heart and soul. However, from a personal perspective, my heart and soul priority remains firmly with my wonderful family here, my mum, my dad, my sister and my niece, and of course to my partner. So a huge thanks and appreciation for all their support, love and permission to just follow my heart and be just me. So thank you all so much.